Good morning and welcome to the 9th meeting of the Health and Sport Committee in 2021. We have received apologies from Alex Cole-Hamilton. I welcome Liam MacArthur, who is attending in his place, and in accordance with Section 3 of the Code of Conduct, I invite Liam MacArthur to declare any interests relevant to the remit of this committee. Liam MacArthur.
Thank you very much indeed, Convener. It's a pleasure to be with you. I'm not aware of any declarable interest, but would of course refer people to my register of interest.
Thank you very much. I would ask all members and witnesses please to ensure that mobile phones are on silent and all other notifications are turned off during the meeting. The first item on our agenda this morning is an evidence session with the Minister for Drugs Policy on the Scottish Government's updated plans and proposals for drugs policy in Scotland. I welcome to the committee the Minister, Angela Constance, who is accompanied by Maurice Fraser and Michael Crook, both members of the drug deaths team in the Scottish Government. Thank you all for joining us today. And Minister, can I invite you to make a brief opening statement? Angela Constance.
Thank you very much, Convener, and good morning to you all. I'm very grateful for the opportunity to come and speak to committee this morning. Following the publication of the 2019 drug-related death statistics, the First Minister announced the need for the Scottish Government to lead a national mission to save lives and to improve lives. In her statement on the 20th of January, she pledged an additional £50 million for each of the next 5 years to drive forward the changes that we needed to see. So our mission aims to get more people into treatment, something which we know has a protective factor and keeps people safe. This is one of my immediate priorities. To do this, we need to improve our treatment offer and make it much more accessible for those whose needs are the greatest. There's already a significant amount of work underway to increase these treatment numbers, including the work of the Drugs Death Task Force. The rollout of the new medication-assisted treatment standards developed by the task force will ensure that a range of treatment options are available to anyone who needs them, no matter where they are in the country and on the day that they request them. It also includes a commitment I have made around increasing the capacity of residential rehabilitation. I have committed to a significant uplift in the current provision of residential placements, and I've asked a residential rehabilitation working group to examine how we can do this quickly. And in addition to that, I'm working on other improvements, such as expanding the reach of examples of good practice, such as heroin-assisted treatment, a service that's currently available in Glasgow but could be replicated elsewhere. We're also working to make long-acting buprenorphine more available as an option for those who would find this more suitable than methadone or other opioid substitutes. These moves would help ensure that treatments would be more widely available, meaning all areas would be offering a more person-centred approach. I'm also working with stakeholders to gear up the way in which we take more account of those with lived and living experience, to ensure that our services, initiatives, plans and policies are informed by the views and experiences of people and their families who've gone through treatment or who are in recovery, as well as those that are currently not in treatment. So to ensure the efforts are stepped up to face these challenges, I will be convening an implementation group where I and other Scottish Government ministers will work alongside Chief Officer or Director representatives from health and social care partnerships, integration authorities and other organisations such as Royal Colleges to ensure that we align strategies and support better delivery. In essence, Convener, to ensure that our public health emergency, our work to save lives, is far better embedded in that wider work to improve lives, whether that's mental health, housing, work on adverse childhood experiences, education prevention, poverty and inequality. And this implementation group will draw on the advice, of course, from the Drugs Death Task Force, but also the new Residential Rehabilitation Working Group, as well as organisations that represent those with lived and living experience, and also families as well. In all of this, to conclude, Convener, partnership working is going to be key, and since coming into post, one of my first priorities has been to meet with as many organisations and individuals that are working in the field as possible. And this has allowed me to hear a wide range of thoughts and opinions about how we make improvements going forward and how we reduce deaths, but also improve the lives of individuals and their families. In my role as Minister, it's my responsibility to build relationships and to work positively with all of these groups. And I'm also absolutely clear on my responsibilities to work with parliamentary committees and parliaments to ensure that we can, going forward, build more of a consensus across Parliament about the direction of travel. So I hope my time with committee this morning, convener, is an opportunity to start building that consensus, and I welcome the opportunity to answer any questions that members have. Thank you.
Thank you very much, Minister. And clearly, as you've described, you have a broad remit, and a lot of the work that you will be taking forward will no doubt be in the area of partnership building, as you have described, and other things. But inevitably, there's a sharp focus on the rate of drug deaths. I think National Records of Scotland reported that that was 3.5 times that of the UK as a whole, and higher than anywhere within the European Union. I should say, before I ask my first question, just to say to your officials, if there is a point at which they wish to come in to offer a supplement to your answer, then they should press R in the chat box in the usual way. And likewise, members will know the routines to follow, but our questions will be covering hopefully the whole range of your responsibilities. But on the question of drug deaths, Minister, I wonder if I can start by asking you what focused action you envisage coming out of the processes you've described this morning to reduce drug deaths coming years.
Yes, thank you, convener. And it's a very important question because there needs to be a really sharp focus. And we need to be focused on leadership, we need to be focused on resources, and we need to be focused on implementation. And the purpose of declaring a national mission to address what is frankly a national disgrace, in essence, is to get more people into treatment, because treatment, the right treatment for the right person at the right time, will provide a protective factor. And that's why, as part of the national mission, I suppose there are 5 priority areas: fast and appropriate access to treatment. All the evidence shows that people need find ways into treatment much more quickly and much more effectively. We have listened to the voices of Parliament and the lived and lived experience community, hence we have a focus on residential rehabilitation. All of our endeavours need to be far more joined up. That's within government and out with government, particularly in terms of community services. There's a clear role for frontline organisations, and particularly the third sector. And as well as we need to overcome the barriers around introducing overdose prevention facilities, but also having a real focus on what we can do now. The heroin-assisted treatment work in Glasgow has been very successful thus far. It's at early stages. So what more can we do elsewhere in Scotland? So our focus is very much on what we can do as quickly as we can, and ensuring that our endeavours, both in harm reduction and recovery, that is pulling together, and that we are all pulling together in one direction. But the point that I think you touched upon earlier, convener, is that very focused work on saving lives also needs to be embedded in the bigger, broader work around improving people's lives as well. And that's where the cross-government endeavour must really kick in.
Absolutely. And I think then, if I was to summarise, would it be fair to say that if I was asking you what is the top priority here, would it be fair to say that you're saying the top priority is access to treatment?
Yes, and the 5 priorities that I've outlined all feed into our focus in getting more people in.
One of the things that was also clear from the National Records of Scotland evidence was that there are particularly high rates of drug deaths in some areas. The city of Dundee, obviously, is one that is clearly particularly affected. but also other places such as Glasgow and Inverclyde. These are often areas of high social disadvantage as well. Would it be reasonable to expect that interventions would be focused in areas with a higher rate of drug deaths, such as Dundee and Glasgow? Minister.
So yes, and there's two things to put that into context. You're absolutely right, convener, that the areas with the highest rates of drug deaths are also the areas of highest rates of deprivation. And we need to pay focused attention to where the problem is most acute. And to help with that, some of the initial emergency funding that we released, in particular the £3 million to alcohol and drug partnerships, was allocated, taking into account the proportion of drug deaths in a particular local authority area. It is also important to say that this is a national, that we can't be leaving behind any area of Scotland. I'm very conscious about the needs of rural Scotland, that some of the issues and difficulties there, particularly in terms of delivering services, can be quite different. And I think we always need to be given special consideration and flexibility to our island community. So absolutely we need to be targeting resources to the greatest need and to the people with the greatest needs. And that points to particular areas of the country. But we must do that in a fashion where we leave no part of the country behind, because this is, after all, a national mission.
Thank you very much. Before I call Emma Harper, there's a brief supplementary question from Sandra White.
Thank you very much, convener. Minister, 69% of drug deaths are men, and that's very worrying. And also in areas, I know Glasgow and others, prescription drugs is a huge issue. I just wonder if yourself has looked at targeting males, obviously, because 69% of the ones who are dying from the drugs, and regarding prescription drugs as well, what we're looking at there. Thank you.
So, in terms of the gender balance, Ms White is absolutely correct to say that in general terms we are mostly talking about men and men over the age of 35. And therefore, there are always particular challenges in ensuring that men can access services. We know with health as a whole that men can sometimes be reluctant in terms of just even going to the GP for more physical ailments. So there are particular issues around reaching men and, dare I say it, men of a particular age. We're also talking about when we look at the drug-related deaths, we're often talking about people with substantial drug-using histories, 20 years, 30 years. And this is where the heroin-assisted treatment project in Glasgow is having some success, particularly in working with people with, extraordinarily lengthy histories of drug use. But what I would also say to Ms White is that the number of women who are dying is increasing, and we must not and we cannot ignore that. We're also seeing an increase over the past 2 years in the number of people under 25 who are dying, and that we're seeing also a quite significant increase in drug-related hospital admissions as well. So we need to have, while there's much commonality across all of these groups, we need to be paying attention to the needs of men, but also the needs of women and younger people. And in terms of the issues around prescribed drugs, the issue that we have in Glasgow and elsewhere is around benzodiazepines, often used with other substances, in particular opioids. And it's illicit benzodiazepines as opposed to prescribed diazepines that we see much more of an issue. And that gets us into the issues of the production of street Valium, which Police Scotland tell me that you can make within hours on a pill press 500,000 tablets and then sell it for pennies. And also, the people who illegally produce these substances have found ways to package it up, put it in blister packs, cardboard boxes, so that it looks, pretty authentic when actually it is not. And there's a whole issue about how you regulate pill presses and deal with illicit benzodiazepine production and use as well as finding alternatives, better ways to treat benzodiazepine dependency.
Thank you very much. I now call Emma Harper.
Thank you, Convener. Good morning, everybody, and good morning to the Minister. In the First Minister's statement, she talked about investing in more public health surveillance so that we could not necessarily wait on annual statistics, that we could look at maybe more focused or targeted info. And you've just mentioned like street benzodiazepines, for example. So, Minister, could you tell me what plans there are to introduce more regular reporting on drug deaths to ensure that responsive and proactive action can be taken, such as more direct data management?
Minister.
So I suppose there's two aspects of this. There is the National Register of Scotland, who are responsible for the collection and publication of drug-related death data. And as Ms Harper pointed out, that comes out on an annual basis. And I am very keen to find ways for much more regular reporting of drug-related deaths information. So work is already underway with Public Health Scotland, the National Records of Scotland and Police Scotland, as well as Scottish Government officials and in-house analysts. Because I think that there is a compelling case to move to more regular reporting, and I want to move to more regular reporting. In terms of other portfolios I've held within government where there has been relevant statistics, I think back to my youth employment days, and other portfolios where there was either monthly or quarterly or biannual reporting. So we need to move to more regular reporting, and I do think that's a very important part of the jigsaw as well. There is also the public health surveillance work done by Public Health Scotland that has improved as a result of the pandemic, and as we begin to look to life beyond the pandemic, I don't want us to roll back on that progress, and actually I want us to build on that progress so that we have better data and information nearer to real time, so that government and services in the community can be fleet of foot in responding to the needs of some of the most marginalised people in our community.
Emma Harper.
Thank you, Minister. Another issue that has been raised in our papers is that there has been some delay in the implementation of the Scottish Government's Drug and Alcohol Intervention Service DAISY database. And I'm assuming that the delay in implementation is probably related to the pandemic, which we've been dealing with as a priority as well. How, Minister, can DAISY be used to inform policy development, and how what impact has the delay in implementing DAISY had? Minister.
Okay, I'm grateful to Ms Harper for that question. DAISY, the Drug and Alcohol Intervention Service, is actually it's a Public Health Scotland tool, and she's quite correct, there's been some historical issues in terms of rolling out the implementation of DAISY, and my understanding is that this has been to do with some of the early pilots that some health boards were taking forward, as opposed to issues with the pandemic. So there are 4 areas that DAISY is now live in, and that is a precursor to the full system coming on stream on the 1st of April. And essentially, I mean, the purpose of this is to get better data that can help us understand the impact of alcohol and drug treatment services better. in terms of who is accessing what services and what the outcome of that is. And given that my focus and the focus that we now have to have right across our entire system has to be on improving delivery and helping us to reach those most at risk and those that are hard to reach. So this work is important, but it is important to say that it builds on existing data that is held by Public Health Scotland. They have two databases, one which is about drug and alcohol waiting times, and one is more granular information about drug misuse. So, much of the information is already available. And my understanding of DAISY is really about getting that information more joined up and in the one place so that it can be accessed quicker and be used to better effect.
Emma Harper.
Thanks, Minister. And you mentioned that there's 4 places that are being piloted or rolling out first, and Ayrshire and Dumfries and Galloway is 2 places, which obviously is very interesting to me as part of the South Scotland region, and the others are Grampian and the Western Isles. Has there been any information received from them as to how it's working so far?
So I haven't been alerted to any difficulties thus far. I mean, it's a very short lead-in phase. So, from the end of last year till April this year. And these authorities were selected because it was such a short implementation phase, such a short lead-in to the full rollout. And these areas were selected because they have smaller populations. So, as with much in technology, it's good to start small, see how it goes. But the full rollout is on course for April this year.
Emma Harper.
Good, thank you. That is my final question, actually, because I was going to ask when we expect the rollout to be complete, and the Minister has just confirmed that it will be by April 2021. So thank you.
Excellent, thank you very much. And I now call on Brian Whittle.
Thank you, Convener. Good morning to the Minister. In a recent blog, Scottish Drugs Forum indicated that some 57,000 people have a drug problem involving opioids and or benzodiazepines, which is 1 in 80 adults. And also a Scottish Affairs Committee, which several of us took part in, the report on problem drug use in Scotland concluded, and I quote here, addressing the root causes of problem drug use require radical whole system change rather than piecemeal reform. And in the Ministerial Statement on Drugs Policy, the First Minister did focus on 5 key areas that we need to address urgently. I just wondered, in the first instance, how were these 5 key areas as set out by the First Minister decided upon, and how will they be prioritised? And I'm specifically interested in how that resource will be allocated. You have said that the alcohol and drug partnerships will really be the gatekeepers, if you like, for that money. And my concern is that there are third sector organisations out there that may lose out on that resource.
Minister.
Thank you very much, and I appreciate that question from Mr. Whittle. He is absolutely right that we need to look at this from a whole systems approach. The government has some experience in this. If you look at the work that was done in and around improvement science within our health service in terms of safety, also in terms of reducing youth offending. So we need a similar whole systems approach in terms of driving down drug-related deaths. And in terms of, how did we select these 5 areas of focus? And as I said earlier to the convener, our focus is very much about getting more people into treatment that is right for them. And also treatment that enables people to access other services and support that gets under the skin of the root causes of addiction as well. And in terms of the 5 areas, the fast access to treatment, residential rehab, much more joined up services, and the front line, which includes the third sector, as well as the work around overdose prevention facilities and heroin assisted treatment. All of that is based on, either international evidence, which Mr Whittle and other committee colleagues will be well aware of, particularly having participated in the Scottish Affairs Committee work. But also, what we know from evidence in Scotland and indeed elsewhere in the UK. And I also, have to say that when I think of evidence, I absolutely, of course, think about clinical advice and research and evidence gathered by academics over a number of years. But particularly important to me, given my background in communities portfolio and in social security, is that voice of lived and living experience and what they are telling us about what is working on the ground and what isn't. And I also want to reassure Mr Whittle that I take very seriously the role of the third sector. Because I know from all my experience in government, and this is my 7th portfolio in government, and also from my experience as a frontline social worker, that the third sector can reach people that statutory services can't. And we've seen during the pandemic that they also can react very quickly and flexibly, and are often the place where innovation can be led from the front. So while I absolutely want to ensure that we fund alcohol and drug partnerships, and I'll be following the money because I want to ensure that the additional resource we have in government that is allocated to alcohol and drug partnerships absolutely gets to alcohol and drug partnerships, and that they, as commissioning bodies, are also having a good partnership with local third sector and grassroots organisations. But I will also fund directly third sector and grassroots organisations too, and we've started that. So with the £5 million emergency funding, 3 million of that went to alcohol and drug partnerships, and we set up 2 funds. One, an improvement fund for organisations to apply directly to. That's a fund for bigger sums of money, and then there was the grassroots fund as well. So going forward, I'll be laying out soon our approach and plans in respect of funding alcohol and drug partnerships, but also in terms of our plans for the longer term in and around funding grassroots and third sector organisations.
Brian Whittle.
Thank the Minister for that answer, and I'm pleased to hear her discuss the importance of the third sector, and because I agree with her 100% that they sometimes have a reach that the statutory services don't, and actually can be the route, the stepping stone into statutory services. So I think it's crucially important that we ensure that our third sector, even though some of them constitutionally could be better than they are nonetheless extremely effective. And I do think it's really important that as part of the process that we bring all of that to bear if we're going to tackle this. So can I ask then, given that, what the analytical work you will undertake to make sure that this work is supported and that the finances and the resource get to where you want it to get to?
Yeah. I mean, in terms of finances to third sector and smaller organisations, I think in terms of early feedback that I've heard from a range of organisations, that we will have to look even more closely at how we can enable organisations to access funds, and also what support we can give organisations to ensure that some of the internal structures within organisations that are required to access funds, that we find a way to support and facilitate that within those on the ground organised organisations. So just because we have announced a £1 million grassroots fund does not mean that that's the end of the story either, in terms of how we improve access or how we increase funds going forward. In terms of the analytical work is very important. Public Health Scotland are developing an extensive programme of research, evaluation and monitoring, and we need them to do this because we need that very close surveillance and detailed analytical work of our national mission. And that's just, I suppose in many ways, that's stating the obvious. Obviously, the task force is investing in research work as well. But the role of Public Health Scotland is particularly important because they already have a responsibility to monitor and evaluate the rights respect and strategy as well, the rights respect and recovery strategy, and that programme is called MARE. So we need to evolve that into something that evaluates a national mission better. In particular, I'll be particularly interested in how we monitor and evaluate the implementation of the medication-assisted treatment standards, which in essence are about the principles and good practice behind delivery of medicated treatments, but also in terms of how we make that link with other treatments that get under the skin of the root causes of addiction.
Ryan Whittle.
Thank you, Convener. Can I ask the Minister how the cross-departmental approach has been taken by the government, in relation to perhaps delivering a more joined-up approach? And in that, I would like to address the issue of, to me, a lot of the discussion just now is about how we deal with people who have fallen into addiction. The other side of that coin is how do we create an environment where people avoid falling into addiction in the first place, and that's going to be around things like community assets and opportunities to engage in other activities within community, and also the hugely important aspect of mental health treatment in addiction. So how's the government working across portfolio to deliver across that whole gambit?
Minister.
So, Mr Phil is absolutely right. There needs to be excellent cross-government work and excellent cross-portfolio work. This is where the implementation group, which I will chair, will really have to come into its own. And I've spent a lot of time and pretty deep engagement with other ministers across various portfolios in advance of establishing the implementation group. So the implementation group and the work that we do to evaluate the work that the implementation group is overseeing is really important. But to give some, practical examples, we know that at least half of those who have problematic drug use have mental health problems. At least half. Yeah. We know that 23% of those who we lost in a drug-related death have had recent engagement with mental health services. So, there is joint portfolio work that Ms Hockey, the Mental Health Minister, and I have already started. So the work of drug policy, will need to be joined at the hip with, work on mental health policy. There is work that is underway in mental health around pathfinders, particularly in Tayside, which is around embedding mental health and addiction services together. Hospital admissions is a key area which the task force have done a lot of work on. So, we know that hospital admissions, whether that's A&E or to psychiatry, as a result of drug-related harms, is increasing. So when people are presenting to hospital, we really need to be immediately plugging them into services. And again, this is where the third sector comes into its own as well. Members, are probably aware of the Medics Against Violence work in terms of peer navigators. So there is work that started to be rolled out in terms of peer navigators, in terms of helping to ensure, people get plugged into community services in terms of drugs and mental health, and that's, particularly important. Unplanned discharges from care, there's a whole body of work in and around that. The other minister that I engage a lot with is Kevin Stewart, in and around homelessness. We know that half of homeless deaths are people who have a drug problem. And again, the work going on there is very much has an outreach focus. So we need more outreach work. And in terms of prevention, there's a big role for schools as well. And of course, the other aspect of this is the work in the justice system as well, about diverting people into treatment at every opportunity to. And the final point, I'm conscious I've spoken at length, and members will have other questions, but we mustn't forget the work in and around poverty and inequality in all of this as well.
Brian Whittle.
Thank you for that answer, Minister. I'll finish with this one, Convener, if I may. Sandra White touched on the prescription drug dependency, and this committee has done quite a bit of work around that, as has the Petitions Committee, which I sat on for a number of years. And I think it's, the conclusion would be that there is an over-dependency on medicalisation of especially around mental health issues. So I wondered what work the Scottish Government can do to potentially reduce the prescribed mental health drugs that are currently that seem to be becoming a problem, and introduce other treatments that will inevitably reduce prescription drug dependency.
So I think we need to just a little health warning when people speak very broadly about the over-dependency on mental health drugs. I'm a former prison social worker and a mental health officer who worked at the State Hospital at Carstairs for 5 years before I was elected to this Parliament. And there are people with severe and enduring mental illness, psychiatric illnesses such as schizophrenia, and the role of medication is crucially important. We need a little bit of care about how we articulate concerns, which can be absolutely very legitimate when we talk about medication. Some of the work that I've been involved in over many years when I was in the field was actually trying to encourage people to take medication to reduce both the risk to themselves and to other people. Saying that, people shouldn't be prescribed medication and not have access to other treatments. People need choices, treatment options about medication. And this is where the medication assisted treatment standards are really important. When you or I go to the doctor on any issue, we are treated like adults, we are given information, we are enabled and empowered to make informed choices about our own health. And we have to apply this here too, in terms of people seeking assistance, treatment in terms of drug rehabilitation. So, and I'm also conscious, Mr Whittle, of the work that the Petitions Committee did in this regard around prescribed medications. And that they were looking at, I think, 5 classes of medication, including prescribed benzodiazepines. And I suppose, as I said to Sandra White earlier, much of the focus of my work is on the illicit use of benzodiazepines, which is quite different. But nonetheless, there has to be links between that work on prescribed benzodiazepines and my work on illicit benzodiazepines and how we reduce that. The Cabinet Secretary for Health has looked at recommendations flowing from the work. There was a short life working group following the petition that was led by the Petitions Committee, and there is a consultation that will be going on from sort of March to June, and that work's been taken forward by the Cabinet Secretary for Health, but we'll obviously keep close tabs on it. But parallel to that, the Drug Treatment Task Force is looking at the issue about how better to treat benzodiazepine dependence, with a particular focus on illicit benzodiazepine dependence. Bearing in mind that if you look at the statistics over the past, since 2009 actually, that there's been a 450% increase in drug-related deaths where benzodiazepines have been implemented. That's very different to elsewhere in the UK, where there's been that increase, and over the same time period, that increase has been 53%, but we have a particular issue in Scotland with illicit benzodiazepines, which is different to the issue about prescribed benzodiazepines.
Thank you very much. And I now call Sandra White.
Thank you, Convener. Good morning, Minister. I wanted to ask some questions about the Rehabilitation Working Group's recommendations, which I think they published on the 4th of December this year. And you did mention about residential places and ongoing treatment as well. And one of the first questions I wanted to ask is, are there timescales for meeting all the recommendations which has been put forward? I know they're very comprehensive, and will the progress be evaluated and reported, or how will it be evaluated and reported?
Minister.
So I would certainly intend to progress in the way that I started by publishing, information that is informative, and we'll want to, publish information about the progress that we are making. And as Ms White has intimated, the government responded positively and accepted each and every recommendation made by the Short Life Working Group on Residential Rehab. And the work intimated is around equitable access, better capacity planning, much clearer pathways into residential rehab, looking at different models of delivery, and crucially how we implement all those recommendations. So that work will progress with pace. I have set up the newly convened residential rehab working group. So while that work continues, I've ensured that there is more money in the system, because there's currently capacity in the system for more people to go into residential rehab. So as well as doing the work to sort out, pathways and access, there is money now in the system to facilitate more access to residential rehab as well.
Sandra White.
Thank you very much. You mentioned, Minister, about pathways, good practice guide on pathways into and from residential treatment. What work has taken? I know you've mentioned about some work that's been taking place and monies that's there, but could you maybe elaborate on the work that's maybe taking place on the good practice guide and pathways? And will that be published? Do you have a timescale for that to be published as well?
Minister.
So I don't have a very specific timescale in mind, but I'm happy to keep committee informed of that, and other to say that we will progress as fast as we can. Some of the work that the new residential rehab group will need to do will be pretty detailed, in and around looking at particular issue about women. There's a gap in residential rehab that is more geared towards the needs of women, particularly the needs of women with children. So, we will want to do that work properly, but as I intimated, each and every year there is £20 million available, going forward, to be invested into residential rehab, and many providers are operating under capacity, so there's already capacity there to be accessed. And in terms of the good practice guidelines, absolutely we will want to do as much as we can, as fast as we can, to encourage alcohol and drug partnerships and other bodies who have a role to play here in terms of using that information to assist on the ground. But there are different services, already available. I met Alternatives from West Dunbartonshire. Folk will also be familiar with the LEAP service in Edinburgh. So there's lots of work to do in and around residential rehab, particularly ensuring that the rehab care and treatment is properly connected with actual care services. And that's why in the medium to longer term we want to take a more regional approach. If people in every part of Scotland are going to be able to access residential rehab, we need to ensure that we've got the right configuration of services and treatment available in different parts of Scotland.
Thank you. This my last question, Convener and Minister also, and I completely understand what you're saying about particularly women having, obviously in Glasgow, it's very difficult to continue a course of rehabilitation if you've got children, so there's got to be a choice. And obviously there's a lot of unmet needs, as you say, about aftercare. How would you evaluate the level of unmet needs in that respect?
Minister.
So again, this is the fundamental work of the residential rehab working group in terms of looking at the best ways to evaluate the impact of residential rehab in Scotland and how we can quickly increase capacity. I've already said that we want to utilise the capacity that's not being used, but we also want to increase capacity, making sure that we're getting the right level of service in the right places across the country as well.
Thank you, Convener.
Thank you. I now call David Stewart.
Thank you, Convener. Good morning, Minister. Good morning to the Minister's officials. My questions relate to COVID-19. The Minister will be aware that the US Centres for Disease Control and Prevention have suggested that the pandemic may have led to an acceleration in the number of overdose deaths. Has the Scottish Government carried out any research in this specific area?
Minister.
So thank you, Convener. Thanks to Mr Stewart. So Public Health Scotland are producing regular surveillance reports and they've been doing that over the course of the pandemic. I'm very conscious that there is much about the impact of the pandemic that we may not fully understand. I am always concerned of the potential for blind spots. We know that in terms of the improved surveillance work that Public Health Scotland has been doing, that we need to continue to build on that. We don't want any stepping back from that as we look beyond the pandemic. I am conscious that while services have done a lot to readapt to providing services in the context of a pandemic, the supply routes of illicit drugs still remain active. So in short, the work that Public Health Scotland is the provider of regular surveillance reports is really important. But also the intelligence that we get from on the ground organisations. So we know much about innovative practice. We know people who have, I suppose, managed to use the time and space that you get from, enforced time and space that you get from the pandemic, to use that, constructively, to access services, who've had to find different ways to reach people. But I'm also conscious of the mental health impact as a result of the pandemic and isolation as well.
David Stewart.
Thank the Minister for her answer. Could I flag up then the work that University of Edinburgh and Stirling are doing on this area? They're doing a joint research project into the effects of COVID and those who use drugs. And I'm sure you're aware and your officials are aware of it, but it's just to say that I think I would certainly endorse the report, and it's certainly worth seeing how this can affect policy making by government. The next question is around decision making around COVID-19 restrictions, and were the needs of marginalised groups such as those who use drugs assessed and taken into account when restrictions were made?
Minister.
So yes, Mr Stewart, much of this work was done by my predecessor as well. So there was work around messaging about when it was safe for mutual aid support organisations, which are crucial to many people in the recovery community, you know, the manner in which it was safe for those to proceed with. So that stakeholder engagement between the government and the information that we've received from NHS boards and others has allowed us to work with services in terms of how they could, have a different approach to outreach. I'm aware from one organisation that wrote to me recently from the recovery community in Glasgow, in the north east of Glasgow, that they are continuing to support around 500 people, which is just, quite frankly, remarkable. They only have face-to-face contact, under certain circumstances, but they're doing much more work online. They're doing a lot of chat and walk type sessions. About a month or so ago, I made an announcement around a significant investment in digital participation, in terms of, and that's a substantial investment of £2.75 million, because many of the ways in which services have improved are not just in terms of how people have needed to reach a service during the pandemic, but some of these improvements have been improvements that people have been looking for a long time. So, rolling out the buprenorphine and the Buvidal, which is a slow-releasing depot injection, and as an alternative to methadone and other opioid substitute therapies, takes people away from that kind of daily interaction with, either a pharmacist or, a medical person, for that daily dosage that, potentially frees up, support services to be working on, the root causes, and frees people up to go on with the other aspects of their life. So Buvidal, we've increased access to that in prisons, and actually the challenge for us going forward is to look at that medication to ensure it's more freely available for people in the community.
David Stewart.
Thanks, Kavita. My final question, and the Minister has touched on this partially in their last answer. What support have drug treatment and recovery services had to remobilise their services?
Minister.
So, it's to the significant credit of drug and alcohol services that they have remained open during the pandemic. Obviously, they have had to find different ways of working. As I've already intimated, some of those different ways of working that we will want to keep hold of because they are to the benefit of people receiving those services. They're indicative of better ways of working. So in terms of the remobilisation plans of the NHS, there's the mental health treatment remobilisation plan, which has specific reference to people with drug and alcohol needs as well. So, it is, I want to reassure Mr Stewart that, drug and alcohol services are part of that remobilisation plan, but actually, many of these services have found ways to remain open during the pandemic.
Okay, thank you.
Thank you very much. And a supplementary question from Emma Harper.
Thank you. Thanks, Convener, for bringing me in. I'm aware, as Minister said, that the alcohol and drug services have stayed open during COVID. Is there work being undergone, I suppose it's part of normal processing for persons who have harmful effects of drugs and alcohol, though they may now be experiencing, I don't know, vascular issues or chronic obstructive respiratory disease issues? Are they part of the prioritisation for a COVID vaccine so that they can maybe enter into recovery, rehabilitation, residential programmes like Auchencruve in Ayr or Phoenix House, for instance? I guess just some clarity around vaccination priority for persons who experience harmful use.
Minister.
So, yes, so Ms Harper will be aware of that the vaccination priorities are around age and health conditions. And she is absolutely right to point to that there is an increased relationship between drug use and physical health problems, in particular respiratory problems, and that those physical problems that go along with drug use are even more heightened for women, actually. So in terms of the general vaccination programme, many people with an addiction will be in that category where they have physical problems, which will mean that they are more of a priority in terms of a vaccination in terms of younger, fitter people. The real issue in terms of the vaccination programme is how we reach those who are hard to reach. And this isn't just an issue for people with addiction problems, it's a broader issue in terms of communities that are more adversely affected by poverty and inequality. So the vaccination plans of every health board have consideration of how we reach those that may be harder to reach. And there's ongoing work within government, again, on a cross-portfolio basis, again led by the DFM in terms of public services work, where we will have ongoing vigilance to ensure that we are reaching people who are hard to reach. But there's a real role here for primary care services as well, where people are engaged with a treatment. Obviously, addiction services, will be able to support people, to access the vaccination, when they are called. But we know that, we don't have enough people involved in treatment. So there's a real important role in terms of GPs and primary care services in terms of identifying those people who are physically vulnerable, whether that's due to a drug addiction or other reason, to be reaching those people, because obviously there's a higher rate of people who are registered with a GP than there is in terms of people who are registered with a drug and alcohol addiction service.
Thank you very much. And I call Donald Cameron.
Thank you, Convener, and good morning to the Minister. Can I take this opportunity to acknowledge her cross-party engagement, particularly with me over the last month since her appointment at the end of last year. Minister, my question is about the causes of drug use and drug dependency. Now, I appreciate you covered some of this already, but essentially on a kind of cross-portfolio basis, how will the factors that cause drug use and drug dependency be addressed? And I'm thinking in terms of poverty, reducing childhood adversity, improving housing, improving employment prospects, and addressing mental health as well.
Minister.
So a core part of this is how services engage with families and how services support families. It's also about how the big universal services of health and education, how they engage and support families that may be in some shape or form struggling. In terms of support to low-income families, in terms of 2019-20, the government invested nearly £2 billion that was quite targeted at low-income households. And in terms of child poverty, which is a piece of work I'm familiar with because I took the legislation through Parliament a few years back, and the Child Poverty Action Plan, Every Child, Every Chance, in terms of it lays out not just actions in terms of putting more money into people's pockets, in terms of reducing people's living costs, how to support affordable housing. It also has some very clear measurements of the impact of the work, again, and work on child poverty is a cross portfolio, and the Social Renewal Board, being led by Ms Campbell and Ms Somerville, will be an important factor in that. But there are certain areas of government that drug policy needs to be joined at the hip with. I spoke quite a lot about mental health and how Ms Hawkey and I will work together on that. But also Ms Todd, in terms of her work as Children's Minister, in terms of having interventions that are much more focused around families and having that whole family approach. And of course, much of this is in the context of being a more trauma-informed nation, and particularly our big universal services being much more trauma-informed, so that they are inclusive of folk with difficulties as opposed to inadvertently pushing folk away.
Donald Cameron.
Thank you for that and for the detail you've provided. I mean, like any cross-portfolio working, it requires coordination amongst the ministers and the officials working on this. How is that coordination happening?
That's my job. That's my job, and that's why I was very keen to pull together an implementation group and a cross-government implementation group. I mean, this is an approach that I started and work a few years back on, say, Gypsy Travellers. And you do need to ensure that you've got all the right folk in the room, and in particular people who can make decisions, and people who can be agents for change, not just within government but also in the community and across local government and across our health service as well. And all of that cross-portfolio work needs to be absolutely well plugged in and well rooted with the work that we will formally and informally do with lived and the living experience communities too.
Donald Cameron.
Thank you for that. Can I move on to the topic of prevention and early intervention, and specifically to ask how will the additional funding that was announced by the First Minister be used to support prevention and early intervention?
Minister.
So the additional money that has been announced has a very sharp focus on the emergency work that we need to do to save lives. But that, as I've intimated a number of times, needs to be plugged into the work that will not just save lives but will improve lives. This is where we get into the real nuts and bolts of cross-government working, because it isn't just about how much of my portfolio budget is spent on prevention. It's actually what's been spent right across the government on prevention, whether that's in health or in education. And I know from speaking to Ms Todd that the launch just in February there of the £4 million Promise Partnership Fund. Now, given the families that are likely to access that, we need to ensure that those families are also connected with the Family Support Delivery Group. The Family Support Delivery Group is connected with the work going on in drugs policy. So this isn't just about how much of my budget is spent on prevention. The bigger question is how much is health and education spending on prevention.
Thank you very much. And I now call David Torrance.
Thank you, Convener, and good morning, Minister. My questions are around children and young people. What estimates does the Scottish Government have of the problematic drug use among children and young people in Scotland?
Minister.
So, what we know from the work that is done with young people, some of the survey work, in terms of, the historically there was the Growing Up in Scotland survey that showed that for young people were participating much less in risky behaviour. There's a more recent Scottish Schools, Adolescents and Lifestyle and Substance Use Survey report in 2018. And it's interesting because it shows that most pupils have never used drugs at all, and that a number of pupils who report using drugs, that's been gradually decreasing since the early 2000s. However, there are always some wrinkles, and when you look at these broad statistics that give a reassuring direction of travel, absolutely. But when you sometimes scratch below the detail of headline statistics, we know, for example, that since about 2013 that there's an increase in the proportion of boys who report to have taken drugs in the month behind them. And what we also know from the drug-related death statistics in terms of the under 25s is that over the past 2 years, each year over the past 2 years, we've seen an increase in the number of young people dying. Now, their patterns of drug use is different. It's far less likely to be opiates. It's more likely to be things like NDMA and cocaine. And we're seeing more hospital admissions from young people as well. That's actually went up by 48%. So, there are big challenges there about how we ensure, as with the general population who have addiction issues, that when people are presenting at hospital because there's been an emergency, there's been an issue, there's been a cry for help, that we do much more faster to plug people into treatment and support that is right for them at the earliest opportunity.
David Torrance.
Thank you, Convener. You've partially answered that, Minister. But is there any specialist treatment services available for children and young people?
So, the specialist approach is around that family inclusive practice, services that take that whole family approach, trauma-informed approaches, our universal services, whether it's health or education, whether it's young people or adults, when they present challenging behaviour, that we're not pushing them away, that we find ways to keep people engaged with services. But there is some interesting research about what's the best way to empower young people to make positive choices. And that tends to be around, in terms of the work within schools, that it's about targeting a range of potential risky behaviours. It's about work that is much more skills orientated, that gives people the skills, the confidence and the self-esteem to be making positive choices. So the work within schools is crucially important here in terms of curriculum for excellence, and I know that they are re-looking at the substance misuse education part of it as well. I mean, people will be familiar with the work in and around Know the Score, for example, and the work done by the Crew, which is about educating and engaging young people around a range of risky behaviours. But there is work going on to reappraise the prevention and the substance misuse education in schools.
David Torrance.
My final question, Convener. How does the Scottish Government's work in relation to drugs policy align with work to reduce adverse childhood experiences and to reduce levels of child poverty?
Minister.
Okay. So I spoke a wee bit earlier about the work across government to reduce child poverty, and unless there are specific points that Mr Torrance wants me to pick up, I won't test the convener's patience. I won't repeat that. In terms of the work around adverse childhood experiences, this is absolutely crucial. I mean, any time you speak to any individual from the lived or living experience community or any of those organisations in the sector who are working with or who represent people whose lives are affected by drugs, adverse childhood experiences is right up there. And this is where the work around getting people into the right treatment, this is where the work around medication-assisted treatment standards is really important, because the medicated assisted treatment standards, the MAT standards, recognise that if you're not just giving people informed choices about medication, that you're also making links to other types of treatment and support as well, and the access to any type of treatment, it really needs to be quick. And of course, the work on ACEs and the work on MAT standards is really important to embed. That this is high priority work going forward. And is I think the best way to demonstrate how to put a human rights approach into practice.
Thank you very much. And I call George Adam.
Thank you, Convener, and good morning, Minister. The question I'd like to ask is, we've obviously, the First Minister announced that there'd be an extra £5 million in this financial year for drug services, and there's a promise over the next term, should the SNP be re-elected, of £250 million over the term of the next section. But that isn't the only money that goes towards the partner agencies that you work with. Minister, do you know how much there would be on top of the money the government's putting in, or will you be able to tell us at one point so we can get the total amounts of money that's getting paid in drug services at the moment?
Minister.
Oh yeah, so Mr Adams quite correct that we have a commitment of £250 million, over the lifetime of the next Parliament, and that there has been £5 million additional emergency money put out in the first or the last quarter of this current financial year, and that money is additional to the existing budgets. And I suppose I can understand why committee is interested in the total pot, because it is comparatively easy, for government to be releasing information about our budgets and our spend and where we've, directed that funding to. Of course, the picture gets a bit more complex when there's public money that comes from health boards in addition to Scottish Government resource, and that there's also local government investment as well. And I am conscious that all of that, at the end of the day, is public money. So while I couldn't here and now, give you, hard and fast figures that includes, health board spend and local government spend, from the top of my head. What I would say, as we move forward to evaluate our national mission, the work that I spoke about earlier, that looks at the success and the outcomes of the national mission, that part of that work is understanding better the overall financial package. And just to say, from my perspective, I will publish as much information as I can. In the next week or so, I will publish the detail in and around the £3 million of extra money that was allocated to alcohol and drug partnerships, and there will be breakdowns from each health board area and each drug and alcohol partnership within each health board area, and people will be able to see where that money has been allocated. We made a very particular ask about the proportions in which money was allocated to residential rehab, improving access to services and harm reduction methods.
George Otto.
And my final question, Convener, and just on the back of what the Minister says, how are we actually assessing the additional spend that we're doing? How are we making sure that we're not getting into a place that the effectiveness of that investment, whereas you may have partner organisations actually spending the same money on similar issues, and how are we effectively making sure that we're getting as much as possible for every penny that's spent in alcohol and drug services?
Minister.
So, thank you, Convener. So this is where we need to have a very forensic focus when we are following the money, because what I want to be absolutely sure of and to be absolutely confident about is that the additional money that the creation of this portfolio has created, that we are getting additional impact for that. That is really, that this is me getting down to brass tacks. I will follow the money, that flows from government, to ensure that we get additionality for that. And this will be part of the work that we'll do as the evaluation programme of the national mission.
Thank you. And Liam MacArthur.
Thanks very much, Convener. I think it's my first opportunity to welcome Angela Cousins to her new role, so congratulations on that. And I know from our previous work together in the education field that comments from Donald Cameron in relation to a collaborative approach is one that the Minister will, I'm sure, bring to this portfolio as well. You'll be aware, Minister, the Royal College of Physicians of Edinburgh published a report last week, amongst other things, backing the introduction of safe consumption rooms to tackle the record level of drug deaths. Professor Angela Thomas, acting president of the college, as well as pointing to support for decriminalisation of drug use, referred to the report saying proposals for key interventions which can be taken now, including the introduction of a drugs consumption room and a heroin-assisted treatment programme in all major centres in Scotland, as we see already at the Glasgow pilot scheme. So I wonder, maybe early days, but whether the Minister has had any engagement with the Royal College or is planning to speak to Professor Thomas and our colleagues, and as part of that collaborative approach, whether we will see progress on the issue of safe consumption.
So the report from the Royal College of Physicians in Edinburgh is really important. It is very welcome. It is encouraging that even from a clinical point of view, that there is acknowledgement of the role of poverty and inequality in all of this, and that there is a deep understanding amongst clinicians that the emergency work that we have to do to save lives, that needs to be embedded across the board in every policy area. There are various Royal Colleges that I will be seeking to engage with. I've certainly spoken to a range of clinicians who are involved, as individuals who are involved with the respective Royal Colleges. And it is very interesting to note that with every expert report or piece of evidence that's published, it very much does point to a direction of travel. Some of this is reinforcing what we already know about the benefits of, for example, heroin-assisted treatment and overdose prevention facilities. I mean, overdose prevention facilities save lives. but they also help people get into longer term treatment and help people make longer term improvements to their life that enables people to have more choices and more chances. So while the report from the Royal College in many ways didn't tell us anything surprising, but it's another layer of evidence of the direction of travel that should be taken. And my approach is to, where I can do something, I will. We will always work, and the example of overdose prevention facilities is an opposite one. I'll continue to work to find ways to do things where the route to doing that may be less than obvious, or where there are legal barriers. But where we can do things, we will absolutely progress with that as speedily as possible. For example, with the heroin-assisted treatment.
Can I thank the Minister? Yeah, thanks very much, Convener. Can I thank the Minister for that response? I mean, I think it tends to suggest that she says this is a direction of travel, and it may be frustratingly slow, but hopefully we will get there eventually. In the meantime, and I know the Lord Advocate has quite a lot on his plate at the moment, but I wonder whether the Minister might commit to engaging with him about what more might be done in terms of the advice that the Crown Office is issuing in relation to the law as it currently stands, that may provide a bit more scope and a bit more reassurance to those who are delivering services which clearly are saving lives, albeit solely in Glasgow at this stage.
So yes, I have engaged with the Lord Advocate and the law officers as you would expect. The government's policy position remains the same. The law officers are fully aware of the government's policy position. Those committee members who were involved in the Scottish Affairs Committee work will be aware of the Lord Advocate's views and what those legal barriers are. Nonetheless, the law officers, the Lord Advocate in particular, gave a view around a specific proposition that came from Glasgow and the circumstances that they are trying to fight in Glasgow, in terms of vast numbers of people injecting and being involved in high risk behaviour, and the Lord Advocate gave a specific view to that specific proposal that came from the Glasgow Health and Social Care Partnership. What I will do is that I will be looking at alternative propositions, and will continue to engage with law officers. But this is a stream of work that my officials are actively engaged in. I really appreciate folks' frustration over this. I share your frustration. I would rather, have the and you won't be surprised me saying this, and I'm saying it as a practical point as opposed to a political one. I would much rather have the powers to legislate, so we could just together be working on legislation to provide a safe legal environment, both for people who use overdose prevention facilities, but also for folk who would work in such a service. However, that will not stop me looking at alternatives and other opportunities to see how we can move this matter forward.
Thank you very much. Thank you very much, Minister, and thank you to Angela Constance and her officials for your attendance today. Clearly, this is an area that will continue to be a major focus of policy going into the next session of Parliament, and that, I think, has been a very useful session. So thank you very much, and we'll now move on to the next item of business, which is consideration of subordinate legislation by the committee. We have two negative instruments before us. The first we will consider today is the Personal Injuries NHS Charges Amounts Scotland Amendment Regulations 2021. Do any members have any comments they wish to offer on this instrument? I see no takers. Is the committee therefore agreed to make no recommendation? That is agreed. Thank you very much. That concludes our consideration of this instrument. The second instrument we'll consider today is the Food Information Scotland Amendment Regulations 2021. Again, can I ask if any members have any comments on this instrument? If there are no comments, is the committee agreed to make no recommendations? That is agreed. Thank you very much. We now move on to item 3 on our agenda, which is consideration of a consent notification proposing that the Scottish Government give consent to the UK Government legislating using the powers in the EU Withdrawal Act 2018 in relation to a UK statutory instrument. That instrument is the Nutrition Amendment and Food for Specific Groups Amendment Regulations 2021. These regulations postpone the date of application for new EU requirements on infant formula and follow-on formula made from protein hydrolysates in line with a recent European Commission decision. This instrument was laid at Westminster on the 19th of February and came into force on the 21st of February 2021. The Scottish Government has advised that due to the urgent need to make the amendment to retain EU legislation before the 22nd of February, prior parliamentary scrutiny of the notification was not possible on this occasion. Can I ask if any members have any comments on this consent notification? If there are no comments, is the committee content to write to the Scottish Government indicating that we are content with the consent proposal and with these regulations? That is agreed. Thank you very much. We now move on to the fourth item on our agenda, which relates to further subordinate legislation, consideration of 4 made affirmative instruments. These are in relation to coronavirus and international travel and are laid under Section 94(1) International Travel of the Public Health Scotland Act 2008. The 2008 Act states that such regulations are subject to the affirmative procedure, except that that procedure will not apply if ministers consider the regulations need to be made urgently. These are then emergency legislation and will cease to have effect on the expiry of the period of 28 days, beginning with the date in which the regulations were made, unless before the expiry of that period, the regulations have been approved by Parliament. And it is for the Health and Sport Committee to consider the instruments and report to Parliament accordingly. These are, in other words, of the same family as many of the instruments we have considered over recent months. And last week we took evidence on COVID health protection travel regulations from representatives of the travel, hospitality and public health perspectives. And today we are to hear from the Cabinet Secretary on the same issues. The instruments we're looking at today are the Health Protection Coronavirus International Travel Managed Accommodation and Testing Scotland Regulations 2021, the Health Protection Coronavirus International Travel Scotland Amendment No. 6 Regulations 2021, the Health Protection Coronavirus International Travel Managed Accommodation and Testing, etc. Scotland Amendment Regulations 2021, and the Health Protection Coronavirus International Travel Scotland Amendment No. 7 Regulations 2021. These regulations impose new requirements of self-isolation and mandatory testing for travellers who arrive directly into Scotland from out with the common travel area and having departed from or transited through an acute risk country. They also make requirements for a managed self-isolation package to be applied to persons who travel to Scotland from England, where otherwise they would be required to comply with equivalent regulations in England. And finally, they remove the Falkland Islands from the list of acute risk countries and territories in Schedule A2 of the International Travel Regulations. So those are the matters before us. But in order to assist our scrutiny, I welcome to the committee once again Michael Matheson, Cabinet Secretary for Transport, Infrastructure and Connectivity, who is accompanied by Craig Thompson, Border Measures Review Team Leader, David Pratt, Policy Lead for the Health Performance and Delivery Team, and Peter Brown, Police Enforcement Liaison and Performance Team. So welcome to all of you in attending today's meeting. We intend to ask questions on all 4 of these instruments in a single session. Questions may therefore be general in nature, although some will undoubtedly be specific in terms of individual instruments. Can I, in welcoming you, invite the Cabinet Secretary to make a brief opening statement on the instruments before us. Cabinet Secretary.
Thank you very much, Convener, and good morning to the committee. I made a statement to the Chamber on the 9th of February setting out the Scottish Government's intention to introduce a comprehensive approach to manage isolation of international arrivals. The regulations which we're discussing today give effect to that policy that I announced during the course of my statement. The principal managed accommodation regulations make it a requirement for non-exempt passengers arriving in Scotland to enter at specific airports and to have booked accommodation in a managed isolation facility to undertake their 10-day isolation period. This applies to all direct arrivals, not just those from red list countries. The managed isolation package includes a requirement to take 2 PCR tests on day 2 and on day 8 of their isolation. Positive test results are prioritised for genomic sequencing to give us an enhanced surveillance regime monitoring importation of variants of concern. Most exemptions from isolation for essential workers also require passengers to have booked and undertaken a testing package. The number 6 amendment made initial technical changes to clarify the application of the rules on travel within the common travel area. This included the needing to take account of red list country arrivals coming to Scotland having not been correctly identified at their point of entry in the UK. This was supplemented by the 3rd instrument, the Managed Accommodation Amendment Regulations. This instrument also makes further technical changes on definitions of testing and offences and introduces an exemption for managed isolation for offshore workers in the North Sea who have transited through other countries. Those workers now self-isolate at home when they return to Scotland. And the final instrument, Convener, as you referred to, is number 7, which removes the Falkland Islands from the list of acute risk countries and territories. This was taken forward on the basis of a revised risk assessment from the Joint Biosecurity Centre. And I'm of course happy to respond to any questions members may have.
Thank you very much, Cabinet Secretary, and there will be questions from members. Can I begin by going back to some of the evidence we heard in our session last week when we discussed the different approaches that are in place across the UK, and as you highlighted in your statement a moment ago, that there are different requirements in relation to, for example, the red list or an overall approach, as you described for Scotland, where regulations apply to everyone entering Scotland from wherever in the world. Clearly, there will have been discussions with other administrations around the correct approach. I wonder if you could briefly summarise the arguments for and against the red list approach and explain why it is that the UK government has favoured a red list approach and what, in your view, is the difference between them and the reasons for the Scottish Government's preferred approach. Cabinet Secretary.
Thank you for your question, Convener. Please bear with me because this may be quite a long question or quite a long answer to your question, but I think giving you the background to this is quite important. When we suspended the travel corridor system, which was operated on a 4 nations basis across the UK, we did so on the basis that the Joint Biosecurity Centre, who had been advising us on the travel corridor system, informed us that given the emergence of new variants, particularly those variants of concern in South Africa and emerging in Brazil, that the travel corridor system and the methodology which they were using for assessing the travel corridor system was no longer fit for purpose. in actual fact, the words that they used was fit for purpose. It was no longer suitable for the purpose for which it was intended. As a result of that, the travel corridors were suspended that the committee is aware of, and the Joint Biosecurity Centre were then asked to develop a methodology that would allow them to identify countries of risk that may have the new emergent variants of concern. Having carried out that process and having produced a methodology which was considered by the 4 Chief Medical Officers of the UK, the Joint Biosecurity Centre then advised the 4 home nations that they were unable to develop a methodology that would have a level of confidence that we could use for the application of a red list system. As a consequence of that, the Chief Medical Officer here in Scotland and in other nations in the UK were unable to recommend taking forward a red list based system because the methodology for doing so was of a very low confidence. As a result of that, the advice which the Scottish Government received, in line with what was highlighted by the SAGE Committee, was that in order to minimise the risk of the introduction of variants of concern, the only suitable mechanism for doing so would be through the introduction of a comprehensive managed isolation programme. And on the basis of the advice which we received directly from our Chief Medical Officer here in Scotland, we took forward an approach which was to introduce a comprehensive managed isolation programme. We raised concerns about the approach that the UK Government were taking, given that the Joint Biosecurity Centre have already advised that they cannot develop a methodology that has a significant level of confidence on minimising new variants of concern being introduced through a geographically specific red list system. However, the UK Government have chosen to take that approach. The approach, Convener, which we've taken here in Scotland is in line with the advice that has been provided by the SAGE Committee, in line with the advice that's been provided by our Chief Medical Officer, and in line with the advice that has been promoted by our Directors of Public Health here in Scotland, and in our view is the most effective way in which to reduce the risk of the introduction of new variants into Scotland and the UK as a whole.
So in brief then, Cabinet Secretary, it would be fair to say that if your approach is based on the advice of the Joint Biosecurity Centre and of SAGE, then the UK Government's decision is despite the advice of the Joint Biosecurity Centre and SAGE.
That would be a fair reflection of the situation we have at the moment.
Thanks very much. If the red list approach continues to be operated for people travelling to England, what impact will that have on the approach, the comprehensive managed isolation programme approach, which has been taken in Scotland?
So, given that the UK Government chose to pursue this red list system, we made representations to them to ask that anyone who is entering a port of entry in England that was then travelling on to Scotland, that they should be required to use a managed isolation facility in England for the purposes of their quarantine period. The UK Government have refused to take that forward. The challenge that then presents is that individuals who have been overseas that are not coming from a red list country or transiting through a red list country are able to arrive into airports or ports in England and then to transit on to Scotland. However, in doing so, they are required to self-isolate at home, and they are also required to carry out, or they're also required to purchase a testing package for once they return home. What we've also done in order to try and enhance some of the risks associated with this is that we have increased the level of contact that is now being made by our National Contact Tracing Centre to those who are returning to Scotland following international travel, where they are self-isolating at home. And over the course of the last couple of weeks, the level of contact has now reached approximately 96 to 97% of all of those who are returning to Scotland following international travel now being directly contacted. by the National Contact Tracing Service. However, we continue to press the UK Government to introduce a more comprehensive system around managed isolation, given the risks that the existing system that they're implementing poses, not just for Scotland, but also for other parts of the UK, given the advice that we've received from our clinical advisors and also from the GBC.
Thank you very much. The effect of this then is, in practice, that there are two classes of people who've returned from international travel to Scotland. One class in managed isolation, where they've landed at Scottish airports, and another class self-isolating at home, where they've come in by a different route.
There are actually three classes, Convener. So there are those who arrive directly into airports in Scotland, where they go into managed isolation, and those who arrive into airports in England but are not on the red list, who can then transit on to Scotland. However, those who arrive into airports in England where they have originated from a red list country or have transited through a red list country require to or should be identified at their point of entry in England and require to then use managed isolation in England. So it's the point of, for the red list system, it's on the basis of your point of arrival into the country rather than the point of your destination once you arrive into the UK. So there are technically three layers here. Those who are coming from red list countries that are meant to be coming to Scotland have to self-isolate when they come into England, and the other two categories that we just touched upon.
Thank you very much. That's very helpful clarification. One other question from me before I pass to colleagues, and that is to refer to the different quarantine periods that exist in different parts of the world, and to ask whether there was consideration by yourself and advisors of the length of stay in quarantine, in isolation or in quarantine for travellers arriving in Scotland. Cabinet Secretary.
The 10-day period was based upon the clinical advice that we received, which was in line with the advice that was provided towards the end of last year in moving the self-isolation period from 14 days to 10 days on the basis that the risk of moving it down to 10 days was significantly lower than had originally been understood at the time when the 14-day period was introduced. Therefore, the advice from clinical advisors was that for a period of managed isolation is that it should be 10 days or 11 nights, which is in line with the period of self-isolation for anyone who is identified as being positive with COVID-19.
Thank you very much. And I now call David Stewart.
Thank you, Convener, and good morning to the Cabinet Secretary and to his officials. Cabinet Secretary, could I raise a big picture issue that I have to confess I've been working on heavily for the last 6 months, and that's about having an internationally recognised vaccination passport to really open up international travel. The Cabinet Secretary will know, of course, covering the Highlands Islands, tourism is our most important asset and product. So clearly I'm looking at the future where we'll have tourists coming safely to our area, and of course Scots travelling all over the world safely. You may know, Cabinet Secretary, that I've raised this with the Cabinet Secretary for Health, with Professor Jason Leitch, at the COVID Committee, Professor Linda Bald and the First Minister. I'm really interested in this project, but also I'm realistic. I understand that there is ethical issues, there's practical issues, there's also this issue with vaccination apartheid, by which I mean poorer developing countries haven't got access to vaccinations. But we do have a track record, as you know, Cabinet Secretary, in things like yellow fever vaccination, and the World Health Organization are vital in this. So sorry for the long run-in and lead-in, but I think this is vitally important to redevelop our economy and tourism, not just here, but across the world. So I'll put my bias to you very strongly at the start, but I would be real interested in finding out what is government's thoughts on this issue, where are we with it, how can we develop it?
Cabinet Secretary.
So grateful to Mr Stewart for his question, because I recognise his interest in this matter and the importance it can play in helping to re-establish international travel. As you rightly highlight, there are a number of ethical issues around the idea of vaccine certification, or as often referred to as vaccine passports. I think they will have a part to play at a later stage as we go forward over the months ahead. We're already engaged with the UK government in this matter. I've already indicated to UK government through our regular COVID-0 meetings that we are looking to work with them on a four nations basis for the development of any vaccine certification process. Our officials in the Scottish Government are also engaged with the World Health Organisation in this matter. The World Health Organisation are looking to try and develop a set of data-specific regulations that could be applied universally across the UK, across the world for the application of a vaccine certification programme. Very similar to that with the yellow fever vaccination certificate. They're trying to create a system that could work on a global basis. So we're engaged in that process. So I agree with you. I think it will have a part to play in the recovery of international travel. We're engaged in that process. However, the benefits of a vaccination or of a certification programme like this do not remove some of the risks that are still associated with variants of concern, and also they are dependent on the scale and nature of vaccination that's taking place in other countries across the world. So, and you rightly say, there is a danger that some countries are significantly behind others just with the rollout of vaccinations, which could have a significant impact on the ability for people to travel in other parts of the world. So we'll have a part to play, Convener. It's something which we're already engaged in, and we are already looking to develop our own thinking around how it would operate through the data system we have within NHS Scotland. But we also have to be mindful of the ethical issues associated with it, but also to recognise that it is not a replacement for issues such as isolation and helping to reduce the risk of new variants being introduced into the country.
David Stewart.
Yeah, can I thank the Cabinet Secretary? I think the Cabinet Secretary is very open and honest about it. And my comments generally are not made in any party political way. I'm very, very enthusiastic about this, but my eyes are open about some of the downsides. But can I raise a very honest view to the Cabinet Secretary? I've been watching carefully what's been happening in Europe, particularly with the Greek Prime Minister pushing the EU ahead on vaccination certificates. I also believe the industry itself will go ahead with this, almost irrespective of what's happening. My real worry is that the Scottish Government's at the station, but the train is already leaving. I am worried that we are falling behind in this issue, and notwithstanding some of the practical concerns, I'm really concerned about it in terms of travel. I do not want to see a vaccination certificate in terms of access to services. There's different arguments for that. Does the Cabinet Secretary recognise my frustration in this issue?
Cabinet Secretary.
So I would recognise your frustration if we weren't already progressing the issue, but we are, and we're already engaging on a four nations basis. So we're looking to try and take it forward on a four nations basis. So that engagement is already taking place. The only note of caution I would have here is that for ministers in Greece to say that they will be looking to welcome people from the UK this summer if they have a vaccine certificate, I think it's far too early to say that will be possible. We don't know what the state of the pandemic will be here at a domestic level. We don't know what the state will be in Greece at that particular point. And we don't know where we will be with the vaccination programme in Greece in particular. So there are a number of different factors out there that will all influence this. So what I would like to reassure Mr Stewart is that we're already engaged in a detailed way around the potential role that they can have and how we could use our existing data system within NHS Scotland to operate on a four nations basis. And that engagement between officials is already taking place. However, their practical operation, in my view, it does require a level of international agreement in order to ensure that it operates effectively and is one which has been adhered to, which is adhering to the necessary data standards for its use. So I think there is still a considerable amount of work to be done at an international level, not only at a domestic level, in taking forward the whole concept and the practical operation of a system like this.
Okay.
David Stewart.
Thank you, Convener. This is my final question, Convener. I appreciate, just before I ask the question, the Cabinet Secretary might not have the information to hand, but my experience in politics, for what it's worth, is that we can all talk a good game. I'm not saying the Cabinet Secretary is doing that, but we require two main things. We require funding and we require staffing. I've asked about staffing to the Chief Executive of the Health Service before, and to date I haven't had an answer. But how many staff are allocated in this project, and what funding's been allocated? Because when I asked Spice to answer this, but my memory serves me correct, they couldn't find any specific funding for vaccination passports. So again, the Cabinet Secretary may see my frustration. Could perhaps the Cabinet Secretary say something about this? Is something happening more than a generalised discussion about this?
Cabinet Secretary.
Well, look, I can pick up on the specific points he's raised with the Chief Executive of NHS Scotland to ask for some more specific information for him. I don't have that information to hand. In terms of the specific funding for staff in taking this forward, my general expectation is that it begin taken forward within the wider funding arrangements within Scottish Government in resourcing different parts of government and taking forward policy areas. So, for example, there's no specific funding for the project team that's been put together for the managed isolation programme. That's been used just from the wider Scottish Government funding budget to deal with the project. So I think, in fairness, it may be that there's not ring-fenced budget for staffing, but it may be at a future stage we will have to provide a level of funding for the rollout of a certification programme. But we're probably still too far away from knowing exactly what that may be. But I'll certainly take away Mr Stewart's point to see if the Chief Executive of NHS Scotland can provide further details around the work that's been taken forward.
Thank you.
Thank you very much. And Cabinet Secretary, as you said, it's impossible to predict quite where things will be at any point over the course of the coming summer. But could you indicate, in your view, what circumstances would need to be in place before managed isolation and quarantine were no longer required at some point in the future? Cabinet Secretary.
Well, the first thing I would say, Convener, we don't want to have managed isolation in place for any longer than it is absolutely needed. And the trigger for ministers starting to move away from the use of managed isolation will be based upon the clinical advice we receive from our Chief Medical Officer and from our Border Health Review Group, who consider these matters in detail. A number of factors that I think will be important in determining that advice. Part of it will be around the rollout of our own vaccination programme, our understanding of the protection that the vaccine provides to the transmittability of the virus, and also its effectiveness against the new variants of concern. Alongside that, the prevalence rates of the virus in other parts of the world. So we know that at the present time, in a significant number of European countries, the pandemic continues to be out of control based upon the assessment that the World Health Organization has made. So a part of our opening up international travel will be around prevalence levels in other parts of the world, where they are with their vaccination programme, and also to points raised by Mr Stewart around the introduction of a vaccine certification programme. So all of these factors will play a part in the assessment which will be used by the Chief Medical Officer in giving advice to Scottish Government ministers on the type of border health restrictions that we need to have in place over the months ahead.
Thank you very much. And I call George Adam.
Thank you, Convener, and good morning, Cabinet Secretary. I would just like to ask, just following on from what the Convener asked you there, is what are the latest numbers of inward flights from red list and non-red list countries in Scotland? And what are the numbers of people staying in managed isolation and the hotel occupancy rates?
Cabinet Secretary.
So at the present moment, Convener, we don't have any direct red list country flights coming into Scotland at the present time. Those flights are banned on the basis of them coming from a red list country. What we do have, though, is you still have flights coming into other parts of the UK where individuals have transited through red list countries and they have been identified at that point of entry. At the present moment, as of midnight last night, we had 254 people in managed isolation in Scotland. The numbers over the course of the last couple of weeks have been gradually edging upwards. However, international travel overall directly into Scotland is at a very low level and has been at a low level for a number of weeks now compared to the levels of international travel we had, say, for example, back in January. So the numbers remain very low, but the numbers of individuals ending up in managed isolation just now is slightly on the increase over the course of the last 2 weeks. But we don't have any direct arrivals into Scotland from red list countries at the present moment.
George Adam.
Thank you, Convener. Yes, Cabinet Secretary, just on the back of that, obviously there's a great concern with the public that there could be potentially people coming in from red list countries and coming into Scotland at one point as well. What kind of communication and how have you made this case to the UK government and with regards to how we're trying to keep the populace in Scotland safe?
Cabinet Secretary.
Convener, that's been taken forward in 2 ways, both by my own direct representation to the COVID-0 Committee and also through written correspondence that's been taken up through myself with Michael Gove at the Cabinet Office on the need to take a more comprehensive approach. There are some ongoing issues that we have with the UK government, so we are at times seeing arrivals on domestic flights in Scotland from individuals who have transited through a red list country, arrived into airports in England, and then transferred onto a domestic flight into Scotland. So some of the noise, the media noise we heard around why are we bothering to have managed isolation at Glasgow Airport when they don't have any international flights other than from the Republic of Ireland? It's for 3 reasons. The first is individuals who are missed at London or in other parts of England who arrive into Glasgow Airport, and we've had several of those. Individuals who transit through Dublin from red list countries and into Glasgow. We've had a number of those who then have to self-isolate at Glasgow Airport. And the third category are those who try to cross into Scotland via the Cairnryan border point using a ferry crossing from Northern Ireland. And we've had a couple of individuals where that route has been identified and where individuals have had to self-isolate. So there are still individuals arriving into Scotland from red list countries, and we have measures in place to try and identify them as quickly as possible and to ensure that they go into managed isolation. But as yet, we have not been able to persuade the UK government to take a more robust approach to the managed isolation system in a comparable way to the way in which we're operating it in Scotland.
George Adam.
Thank you, Convener, and thank you, Cabinet Secretary. That's all very concerning and worrying. My final question would be, we had the airports and hospitality sector in last week and we were asking them questions, and obviously when you had to create this policy and put it in at speed, they complained that there was not enough consultation between them and yourselves. What challenges did you have, Cabinet Secretary, developing and implementing this policy at that pace? And are there discussions now underway with the aviation hospitality sectors to draw on lessons learned from the haste which you had to get the policy up and running?
Cabinet Secretary.
Convener, I very much appreciate the concerns that were raised by the aviation sector, particularly airports, around the speed at which this policy had to be introduced. There are two parts, though, I would take from the question asked by Mr Adam. There were some who were challenging us around the lack of consultation in taking the policy forward. Given the clinical advice that we received, it was very clear that the Scottish Government had to move in this issue quickly. And we sought to try and coordinate that with the UK Government. So it meant from the time when it was highlighted to us that we needed to take action to implementation of the policy, is there was no time to undertake a consultation around whether we should introduce it or not. The advice was very clear. The challenges we had around being able to engage in a more detailed way with our airports was largely on the basis that, and it wasn't the fault of the UK Government, we agreed to take forward the managed isolation policy on a formations basis, so under one single contract for the whole of the UK, which means that the standards, the policy approach and also the implementation of the policy was consistent across all of the airports in the UK. And some of the process in managing that contract was being taken forward by the Department of Health and Social Care, controlled by the UK Government, which limited the scope to which we had control over the rollout of some of the implementation of the policy. Alongside that, parts of enforcement are dependent upon border force, which had to be taken forward through the Home Office. So we did our very best to try and engage with our airports at the point in the lead up to the policy decision, but also when it was being implemented. But there were constraints around that because of the speed at which it was having to be introduced, and also some of the key parts of it were being taken forward by UK Government departments. And as a result, the level of information we had at certain key points was limited because of that process. So I accept it was far from ideal, but we sought to manage it as effectively as we could and to engage with them as much as we could and to provide as much information as possible when we had that information to hand.
Thank you very much. I now call David Torrance.
Thank you, Convener, and good afternoon, Cabinet Secretary. Why has it been necessary to bring in a series of different regulations over a short timescale, and can the Cabinet Secretary explain how they will all fit together?
Cabinet Secretary.
Yeah, Convener, some of the regulations that we've introduced are based upon in order to close down some potential anomalies in the system. So, as I mentioned earlier on, individuals who are arriving from red list countries in ports in England or airports in England, but travelling on to Scotland should be identified by Border Force at the point of entry. And the regulations were originally drafted, for example, on that basis. However, it then became apparent that there were some individuals who were getting through the system, and therefore the regulations had to be amended to ensure that individuals who were arriving from red list countries from a flight within the common travel area could be required to go into managed isolation when they arrived into Scotland. And as I mentioned, that's one of the reasons why we have a facility at Glasgow Airport. The other reason that part of the regulations have changed is to accommodate some of the issues that the oil and gas sector had. So, for example, individuals who work in the Norwegian sector very often go from their platform straight to the airport that they're then transiting back from into Scotland. And on the basis of clinical advice that we received, that the risks associated with this were very low. We sought to provide an exemption to accommodate that and to allow them to self-isolate at home rather than in a facility. And in the other area, it was in relation to the regulations was in relation to the risk assessment of the Falklands Islands changing, and therefore we amended the regulations to take account of that.
David Torrance.
Thank you, Cabinet Secretary, for that answer. Cabinet Secretary, can you indicate what degree there is now of an understanding of the new rules, and what is the plan to communicate the new rules in a simple and comprehensible way to the aviation, hospitality sectors and the wider public?
Cabinet Secretary.
So there is now information which is on the Scottish Government's website that provides you with details of the policy around managed isolation, and it also has details and information around the exemptions which are provided for within the exemption within the regulations. We now have we've regular dialogue with the airports, so the project team that are managing the managed isolation programme have regular contact with them. With the hotel providers, the security service that are providing support, and also the transport providers. And we're also ensuring that where there are any issues of concern with the airlines, that we are picking up these issues through Border Force, and to ensure that the Civil Aviation Authority are also providing the right information to airlines who are providing direct flights into Scotland. So we have a whole range of different measures now in place, Mr Torrens, to ensure that people can access the relevant information and also maintain ongoing engagement with the airlines and with their airports around any issues that may emerge as we go forward.
Thank you very much. Cabinet Secretary, you mentioned that provision is now made for offshore workers who work in the Norwegian sector to self-isolate at home on return, albeit that they transit through airports in Norway. I know from constituents of mine that there are also quite a number of Scottish oil and gas workers who work onshore in Norway and who raise the question of why their requirements are different from their offshore colleagues, given the very tough border controls and very low prevalence of COVID in Norway. Is that a matter that you have considered in the same context as the offshore Norwegian sector workers did?
It was considered, Convener, and the clinical advice was that we should not provide an exemption for that purpose. The reason for the exemption that we provided for at the present moment is, as I mentioned, it is for individuals who, when they arrive in Norway, will have to go into a period of self-isolation. They will then go onto their platform or vessel for their period of offshore working, and very often will then transit back to the airport directly that they are then flying out to Scotland from. So they are only effectively transiting through that airport for the purposes of returning to Scotland, which is different from individuals who are actually staying and working in Norway. And on the basis of the clinical advice which we received is that they viewed an exemption only for those who were transiting through the airports in Norway for the return to Scotland that should be provided with an exemption. I'm sure you'd also appreciate if we started to introduce what would effectively be a corridor system specifically for one group of employees in one country, that we would then face demands for similar arrangements to be introduced for other groups of employees in other parts of the world, and therefore that would undermine the intention of our managed quarantine programme. So we've taken forward an exemption system which is based upon the clinical advice which we've received in this issue.
Thank you very much, Cabinet Secretary. I would simply note that those workers travelling from Scotland to Norway to work onshore also require to isolate on arrival in Norway before they begin to work, even though that is onshore. But I'm sure that is a matter that your clinical advisors will be aware of. I now call Donald Cameron.
Thank you, Convener, and good afternoon to the Cabinet Secretary. Can I begin by asking about the governance of this work within the Scottish Government, in light of the fact that it cuts across portfolios, that there's a division of responsibility between health and transport, for example. How is that working internally?
Cabinet Secretary.
So the process that we have in place for governance around these matters is through the Border Health Review Group, which is made up of officials from health, justice, transport, external affairs, who are considering all of the different component parts around our border health restrictions. And they're reviewed every 28 days in line with the regulations that we introduced earlier this year. So we have a border health review group that brings together all the different disciplines to advise us on these issues, and then we have the 28-day review period to determine whether they need to be maintained going forward.
Donald Cameron.
Thank you for that. Moving on to the Four Nations approach, we had quite powerful evidence last week from Mark Johnson of AGS Airports, who said that he was looking for a system that was simple and consistent. What have been the logistical challenges of a Four Nations approach? And I asked that question in the context of the fact that Wales and Northern Ireland have taken an approach that is more similar to England than Scotland. So I wonder if you've had discussions with those administrations as well in trying to overcome these logistical challenges.
Cabinet Secretary.
So for Wales and Northern Ireland at the present moment, they don't have any international flights coming into their airport. So at the present moment, they don't require to have a managed isolation programme in place. Although my officials have been engaging with them because they have been asking for some advice from us on our own experience in introducing the managed isolation programme. On your specific point around the logistics of introducing this, they have been significant. So from the practical operation of putting in place the hotel arrangements, the transport arrangements, the security arrangements, ensuring that border force staff were appropriately trained and informed of the way in which the regulations would operate, the introduction of a booking portal system so that individuals prior to their point of departure are able to book their period of managed isolation or their testing package, all of which had to be put in place at very short notice. So all of these arrangements have presented significant practical and operational challenge, but by and large the staff have managed to introduce them very well. As ever, when it comes to operational issues, and as a Transport Secretary and Infrastructure Secretary, I'm very aware of the types of operational challenges that can arise with issues like this. However, by and large, the system has operated very well since it was introduced, although there are still some changes that need to be made to the operational arrangements, particularly around the welfare fund arrangements, which we're continuing to work with the UK government on. And the only final point I make, Convener, is that we sought to take it forward on a Four Nations basis to try and help to minimise some of the operational risks of different parts of the UK having different standards and different charges for the introduction of managed isolation packages and for testing packages.
Donald Cameron.
Thank you for that. Going forward, if the other three nations of the United Kingdom maintain their current approach, I wonder what the options are for the Scottish Government. And I'm particularly thinking of the issue I think we all acknowledge, which is of someone, say, flying into Newcastle or Manchester or Belfast when the time allows it, and then travelling into Scotland, and only being required to isolate at home rather than in managed accommodation. Is there any legislative option that you're considering in that respect?
Cabinet Secretary.
I think it's worth just keeping in mind is that as I pointed out, the Northern Irish and the Welsh government don't have any international flights at the present moment, so they are dealing with individuals who are travelling into the country from overseas. I know the Welsh government and the First Minister there has indicated he would prefer a green list system rather than a red list system. I think there is some merit in that in terms of managing our exit out of the use of managed isolation. However, I think the important thing, particularly for a committee like the Health Committee, is that if there are lessons that we need to ensure that we learn from this pandemic, it is a need to move early and to do so in a decisive way. And if the clinical advice is very clear and very strong, that we need to have a comprehensive programme of managed isolation in place, particularly during the rollout of our vaccination programme and the risks associated with variants of concern, then it is incumbent upon ministers to respond to that. And that's exactly the approach that we have taken in Scotland to try and to effectively implement the clinical advice which we've received. I've got no doubt, had I been here, been invited by the committee, and I was saying to you that I was ignoring that clinical advice, I would expect the Health Committee to have significant concerns around that. But I think in general, Mr Cameron, the key here is going to be about how we manage our exit from the use of managed isolation, not just in the approach that we're taking here in Scotland, but also in England, that we do so in as aligned a way as we can, so long as it is based upon the clinical advice and on the data around where the pandemic is at any given time as we start to ease these restrictions. But we're probably still some way away from that. But we are continuing, though, to press the UK government to introduce a more comprehensive system, because that would be safer for Scotland, and it would also be safer for other parts of the UK, based upon the expert clinical advice that we've all received.
Thank you very much. And Cabinet Secretary, I'm bound to come back to my constituency interest in the situation in Norway when you talk about the potential for a green list and how that might apply to those countries, presumably with very low prevalence and very secure travel. Could you indicate, you mentioned the Joint Biosecurity Centre and SAGE having been found no basis for a red list. Have they been consulted or given advice on the potential of a green list as a way out of the current situation? Cabinet Secretary.
Not at the moment. Unfortunately, Convener, and I think it's important the committee is aware of this, is that the Joint Biosecurity Centre have already carried out a review of the existing red list countries and submitted a report to the UK government on their review of the red list countries. However, to date, the UK government have withheld that report from us. I've made representation to the UK government on this matter, and I know colleagues from the other devolved nations have made representation to the UK government on this matter, because the Joint Biosecurity Centre works on a four nations basis. However, the report is submitted to the UK government. So the most recent review of the red list countries by the Joint Biosecurity Centre has been withheld from us, and we are continuing to press for that advice to be provided. At this stage, they have not been commissioned, though, to start looking at the creation of a green list system. I'm only suggesting at the basis of it's one of the issues that the Welsh Government have raised, or I know the Welsh First Minister has suggested, and I think there is some merit in it being explored as well. But I am concerned that the expert advice from the Joint Biosecurity Centre on the existing red list system is now being withheld from us, and there is a need for that to be addressed urgently. And I made representations to the UK government at the COVID-0 meeting just last week, asking for that advice to be made available to us, but to date it's still not being provided.
Thank you. And very briefly, could advice on a green list be commissioned by the Scottish Government alone, or would that have to be in agreement with of all four of them?
I think it would be best taken forward on a four nations basis as a potential route out of the use of managed quarantine, and also alongside vaccination prevalence rates and vaccine certificates. So I think it has a potential role to play. It may be that through the work that we are taking forward with the aviation sector around our aviation working group, and also our engagement through the Global Travel Task Force, that these are issues that will be explored further as we go forward. But at this stage, it's probably too early to say whether that's the route out. It just may be one of a number of different options that could be considered.
Thank you very much. That's very helpful. And I have a supplementary question also from Emma Harper.
Thanks, Convener. Just a quick supplementary question about what does the Cabinet Secretary have in his toolbox to manage the practicalities of the Scottish and English border, because we saw just before Christmas that the Kent variant just totally spiked in Stranraer, and then there were other wee outbursts in Gretna and Annan, and I know how people have spoken before about the essential cross-border travel requirements, whether it's for essential working or essential services. Is there something that the Scottish Government can do to manage the border in a way that can support keeping the virus reduced on the Scottish side of the border, given that the UK Government released lockdown a bit faster than maybe we would have liked previously?
Cabinet Secretary.
So I recognise the issue and concern that Emma Harper has around this particular issue. One of the challenges around introducing specific checks at the border between Scotland and England is the volume of traffic that crosses the border on a daily basis for a whole variety of purposes. But one of the key issues that can play a part here is having a consistency of message around people only travelling for essential purposes. And I have, again, raised concerns with the UK Government around some of the mixed messaging we're getting around the possibility of people being able to travel for leisure purposes at various points. And it's important, I think, at this stage that all UK governments continue to emphasise to individuals that they should only be travelling for essential purposes. And if people comply with that, and if they adhere to that message, it minimises the risk of the transportation of the virus, not just from England into Scotland, but also potentially from Scotland into England. So I think all the formations need to be as consistent as possible in getting that message across to the public. So one of the issues that we regularly discuss with their counterparts in other parts of the UK is making sure there's a consistency of that message. And there have been occasions where it's been quite frustrating that hasn't been the case. But I think that's probably the key thing that we could maintain just now to try and help to reduce the risk of people travelling unnecessarily between Scotland and England and Scotland, and potentially Scotland and Northern Ireland from your own constituency where it's not essential.
Thank you very much. I call Sandra White.
Thank you very much, Convener, and good afternoon, Cabinet Secretary. I just want to ask a couple of questions in regards to the testing regime. You had already mentioned earlier on, I think, an answer to Donald Cameron about their operational challenges, obviously when they manage isolation and the testing package, as you called it. Now, we know that PCR tests are being conducted in the second and eighth day of people isolating, and the test will be self-administrated. I just want to ask Cabinet Secretary, will people who are testing themselves and they're in quarantine, will they be supervised when they're undertaking the test to ensure the tests are conducted properly? And who actually gives them the test, who actually receives the test, and basically who's responsible for looking after the tests and the results as well?
Cabinet Secretary.
So, Convener, the test is self-administered, so not supervised at the time when the test is actually carried out. So whether they're in managed isolation or whether they're carrying it out at home. In the managed isolation facility, the test is returned to security at the hotel, who then pass it on for it to go to one of the labs for the test to be carried out. I'm afraid I don't know off the top of my head exactly which lab it goes to directly, Convener, but I can check if that information would be helpful for Sandra White. But then what happens is that the test results from that test, if it is negative, is shared with Public Health Scotland. If the test comes back as positive, Public Health Scotland will then require it to be genomically sequenced in order to see whether it is a variant of concern. And then if necessary, if it is, then they obviously have a standard process for dealing with that through the local health board and their incident management team, and also with the security providers at the airport. So the results are collated by Public Health Scotland, and if a positive test comes back, then the individual concerned will be notified, and genomic sequencing will then take place, and the local health board will be engaged in any management issues associated with that individual, whether they're in managed isolation or whether they are self-isolating at home.
Sandra Hart.
Thank you for that. So basically, whilst we are going down to Louisa Jordan, wherever we are, in our case in Glasgow, Louisa Jordan, somebody is taking the test. So in this instance, people are handed the test by the security, which is a UK situation, the Four Nations one, which is G4S, private firm. So they, I take it, these tests are stored in the hotels. They're handed over to the person in the room, and then the person gives it back to the security guard, who's G4S, and then they're sent somewhere, basically. We don't know, and I would really like to know exactly what testing centre they're sent to. And also, how quickly can these results be processed? If they're proven to be negative, you said that's, well, it's not fine, but it goes through Public Health Scotland. And then if it's proven to be positive, then it also, Public Health Scotland is responsible, but it has to go through the Four Nations approach again. Is that correct? So is this what happens? So you don't really know if these people are actually taking that test properly, if there's nobody there supervising them.
Can I perhaps suggest that Craig Thompson might want to come in at this point? I know he's indicated a knowledge of the issues involved. Craig Thompson.
Thank you, Convener. I just wanted to build on what the Cabinet Secretary said. So these are UK home testing kits, essentially, that are specially labelled, so they're prioritised when they go into the Lighthouse Lab system. So they go into the UK Lighthouse Lab system. As the Cabinet Secretary says, the results are passed on to Public Health Scotland for contact tracing. The turnaround time would generally be within 2 days. And so the test on day 8, the purpose of that is largely to ensure that when we get to the end of the isolation period, the 10 days, that we have an assurance that the individual has tested negative. But they're the same standard PCR tests as the home testing kits that are used in the UK Lighthouse Lab system.
Thank you very much.
Thank you.
And thank you. And now call Brian Whittle.
Thank you, Convener, and good afternoon to the Cabinet Secretary. Can I ask the questions around the procurement process and what involvement the Scottish Government has had in the procurement process for the managed quarantine services, for example, transport, security and hotels? And is the Scottish Government satisfied that all aspects are specified to a high enough standard, for example, in terms of the facilities and quality assurance protocols?
Cabinet Secretary.
So, good afternoon to Mr Whittle. The way in which the contract has been taken forward for the delivery of managed isolation in Scotland for the provision of the hotels, transport and security is through a single contract at a UK level. So the standard specification, the standard operating procedures in being used in Scotland are the same as they are for other parts of the UK. There are some slight variations to it. So, for example, the information that guests arriving into hotels in Scotland receive is Scottish specific. So, for the contact helplines and for contacting breathing space or support helplines is Scottish specific services. But so the contract is a UK wide one. And it is operating on the same standard operating procedures with some minor variations to how it operates here in Scotland. In terms of standards, so the standard of the hotel is of a 3 to 4 star type hotel. which is specified in the contract. The specification of what has to be provided by the hotel provider is set out within that, alongside the responsibilities of the security provider and also the transport provider. As in terms of how they're operating at the present moment, from an operational point of view, they are operating well and to the standards which have been specified. But as I mentioned, there are some slight variations to the Scottish contract, or the Scottish element of the operating procedures, which are reflective of just some of the specific circumstances we have here. So, for example, individuals being collected from the port of Cairnryan and transported to a managed isolation facility at Glasgow Airport is specific to Scotland because of the potential port of entry there.
Brian Whittle.
Thank you, Convener. Thank you for that clarification, Cabinet Secretary. Can I ask then just simply who's monitoring the quarantine hotels to ensure that there is full compliance with the infection controls as stated?
Cabinet Secretary.
So there is discussions that take place with the project team in the Scottish Government and also with the UK Government and the hotel providers, security providers and the transport providers. They take several times a week to cover any issues that have been highlighted to our project team and for the UK Government to raise any issues they have from their project team with the operators, and also for any issues that operators may have that need to be addressed as well. So there is a daily level of engagement that takes place to identify any operational issues or concerns that have been highlighted both from our side and also from the operator's point of view, so that they're addressed quickly.
Brian Whittle.
Thank you. Well, following on from that, I wonder if the Cabinet Secretary has any concerns about the potential weak links in the chain of infection control. I'm thinking specifically perhaps of lessons from the Australian experience. It's indicated that hotel transfers or the employment of private security staff might pose a risk.
Cabinet Secretary.
So there are certain protocols in place for security staff and also for hospital staff. So they are subject to testing prior to the start of their shift. So they are tested on a daily basis in order to identify any early risk of staff being infected. Alongside that, there are very clear protocols for the hospitals and security guards in managing individuals. So, for example, hotel rooms, when they're vacated by an individual, are left for 3 days before cleaning staff enter the room for it to be cleaned. Additionally, when individuals have been transported, is that there has to be the appropriate levels of social distancing and masks being worn on the coaches. So sometimes there are more than one coach taking a small number of people in order to make sure that that's maintained. Staff also within the hotels, the rules are very clear, is that individuals are not able to leave the room unless it is agreed with the security staff in order to make sure that they minimise the potential risk of individuals coming into contact with other guests and with staff as well. Meals are left at the door rather than taken into the room. So there are a whole range of different measures that have been built in to try and help to minimise that risk, Mr. Whittle, as best we can, alongside the daily testing of staff in order to identify any staff who may become infected as early as possible.
Brian Whittle.
Thank you. My final question, Convener, is around just to see if I can get the Cabinet Secretary to confirm that the managed quarantine programme it doesn't have a cost to the Scottish Government budget, or there are some cost implications that we need to know.
Cabinet Secretary.
There will, Convener, in the end be a cost to the Scottish Government for this policy. However, it's been taken forward in a single UK contract at the present moment, and what will happen as we move forward in the months ahead is that the costs for the Scottish helping of it will be disaggregated, and that will be met by the Scottish Government. What I can't say at the present moment is what those finalised costs will be, because the overall cost of the programme across the whole of the UK it will still emerge as we go forward in the months ahead. But the Scottish element of it will be met through the Scottish Government, which will be disaggregated from the specific part of the contract that applies to Scotland.
Thank you very much. Thank you. I now call on Emma Harper.
I will try and make my questions really succinct, but Cabinet Secretary, it's about the health and well-being of staff at the airports, as well as people travelling through to be then put into managed quarantine. Can you tell us what concerns you have about the well-being of the staff at the airports, and also what is being done to support the human rights and the welfare of travellers that are being moved through the airports as well?
Cabinet Secretary.
So our airports and airlines have had arrangements in place for some time now in managing people moving through airports and onto and off of aircraft in order to try and maintain social distancing. So those protocols that they have in place apply as they stand at the present moment. Alongside that, there is a requirement to make sure that individuals who are coming through the airports and are moving on to a managed isolation facility, that the process that the security staff have and the transport providers have, and at the airport and the hotels at point of arrival are all compliant with the need to maintain social distancing and to minimise the potential risk of direct contact with guests or travellers. So the operating procedure that's been put in place is one which seeks to try to help to minimise that potential risk and to help to protect the staff. I know that my officials leading this project had a discussion, I think it was towards the end of last week, with the trade unions that represent the staff who particularly work in our hotels providing this service, and went through with them the arrangements that they have in place to protect hotel staff. And the feedback I had from officials was broadly that the unions were content with that. But I can assure you that if there are any issues that do arise or emerge that would be a matter of concern for staff welfare, then I would expect those issues to be addressed swiftly in order to minimise that risk.
Emma Harper.
Okay. Thanks, Cabinet Secretary. And just a final question. I note that the cost of the managed quarantine is £1,750 for the first traveller, and then £650 for an additional adult or child over 12. I'm sure part of the well-being and welfare concerns is that there are people that have indicated that they might not be able to meet those costs. How do we support people that might need an additional welfare package or some kind of support in order that they aren't burdened and cause additional impact because of the £1,750 of cost?
Cabinet Secretary.
So, Convener, there are two elements to this. So the first is in relation to those who may not be able to afford the upfront cost, and if so, they can choose a deferred payment programme where they can pay it up over an extended period of time. And there are those who are receiving qualifying benefits that would suggest that they are unable to meet the costs associated with managed quarantine. We're in there is still some further work that needs to be taken forward to ensure that the welfare provisions are operating effectively and on the basis of how we want to operate them here in Scotland. And there are some points of difference between the UK Government and the Scottish Government on this issue. So, for example, the welfare arrangements for those who may be on qualifying benefits for a deferred payment is that the UK Government's preferred approach is that the repayment will be deferred and will be deducted from benefits. Our view is that for individuals who may be on qualifying benefits is that they will have the fee waived. and the single booking app that provides for this, that the UK government has, at the present moment isn't able to accommodate both of those options, and we're engaged with the UK government around looking to have it amended to reflect the approach we want here in Scotland, and that is that those who do qualify for welfare support where they are in a qualifying benefit, is that the fee is actually waived rather than deducted from their benefits going forward. And my officials are continuing to press to try and get this amendment carried out to the system, which I would hope will be progressed in the coming days. But it's an issue which we've been trying to get resolved for a couple of weeks now, as it clears a matter of concern for those who don't feel they can meet the costs associated with managed isolation. But the engagement we've had with the UK government in this matter has been very positive. What we just haven't got to the point of is getting the changes made to reflect the different approach we want to take here in Scotland around waiving fees for certain individuals.
Okay, thanks.
Thank you very much. Emma Harper.
Just a wee final question, and I'm sure the numbers are very small that this amendment to the system would require, but the constraints of the UK government's approach, is that impacting people that do want to seek to come back to Scotland and but yet have challenges in the fact that they might need this funding waived?
Cabinet Secretary.
No, I don't think it is. What will happen at the present moment is that if someone's on a qualifying benefit, they'll be able to indicate that they are looking for a deferred payment. So it won't prohibit them. The issue is how we then deal with that afterwards. And the way the booking system operates at the present moment doesn't quite reflect how we want to deal with that. And that's why we're looking for some amendments to be made to the system. But I'm not conscious of anyone who's been unable to return. I may be wrong here, but I'm not conscious of anyone who's been unable to return as a result of the existing arrangements. You know, I'd be more inclined to, if someone needs to get home, I'd be more inclined for them to get home, and we can deal with the issue around the finances later. And the deferred payment system allows that to happen. It's just about how we then follow that up, and we need an amendment to the system to be able, in certain circumstances, to waive the fees for individuals who are on certain, a limited number of qualifying benefits.
Thank you very much, Cabinet Secretary. The Managed Isolation Welfare Fund that you referred to earlier, does that go beyond the deferral or waiving of fees? Is there more to it than simply that, Cabinet Secretary?
Yeah, there are some. It is limited to the benefit criteria, convener. Although there are a couple of other exemptions from individuals for welfare purposes where they don't require to use managed isolation. So, for example, an individual who's returning on a family reunion visa, where they will be able to self-isolate at home instead, or someone who is coming to Scotland for the purposes of as a refugee or in seeking asylum, again, where they have a designated place of residence to go to, they can self-isolate there because of some of the restrictions around their entry into the country, and some of the welfare issues associated with it. So there are some other welfare provisions that are associated with the reason why the person is coming to the country, beyond that of just the financial cost of the actual managed isolation package itself. I hope that's clear.
It is. I refer to a case, you mentioned you weren't aware of cases. I refer to a case of a student who, for compassionate reasons, has been in Germany and wishes to return and fears that she simply couldn't afford the fees for managed isolation in a hotel. Clearly, being a student does not of itself constitute being on a qualifying benefit. What would the position be for somebody in her circumstances?
You're correct. Being a student isn't an automatic qualification for that. So I don't know what their wider financial circumstances would be if they are on other qualifying benefits. But there may be circumstances where they would, if they are on the right benefits, to to benefit from a deferral scheme, but it would be dependent on that individual circumstances. But being a student in itself isn't an automatic right to having the fee waived because of the benefit qualification for any deferral system, any deferral scheme.
So essentially, without a qualifying benefit, somebody in that position simply wouldn't be able to travel.
If they're just travelling to the country for the purpose of returning home, they wouldn't be automatically exempt from the cost.
Okay, thank you very much, Cabinet Secretary. That's been a very comprehensive session. Thank you for your evidence today and for the attendance and contribution of your officials. We will move on to the next item of the agenda, which is the debate on the motions in relation to the 4 made affirmative instruments on which we have just taken evidence. Members have previously agreed that we will take these instruments together, and I just want to confirm that with members before we proceed. Are members content to a single debate being held covering all of these instruments together on which we have just taken it? That remains the case. Thank you very much. We therefore move to the debate phase. The members will not put questions to the Cabinet Secretary. There is an opportunity to speak, of course, for members and for the Minister, not for officials. Can I invite the Cabinet Secretary to speak to and move motions S5M 24146, S5M 24189, S5M 24262 and S5M 24253, all in his own name. Cabinet Secretary.
Convener, can I move all the motions in my name?
Thank you very much. Do any members wish to contribute to debate on these 4 motions? Brian Whittle.
Thanks, it's just a point, Convener. I think we're in danger, I'm listening to the conversation we're having here, we're in danger of conflating 4 nations approach to to our Westminster government. I think we have to. If we talk about 4 nations approach, we have to be careful here that we talk about 4 devolved nations. And just say it's just a point, Convener, but it just starting to rankle with me a little bit that if it's a 4 nations approach, it's four different nations. It's not just one.
Thank you very much. Are there any other members who wish to contribute to the debate? If not, can I ask the Cabinet Secretary to sum up and respond to the debate? Michael Matson.
I've got no further points I want to cover, Convener.
Thank you very much. I will therefore put a single question. The question is that the motions S5M 24146, S5M 24189, S5M 24262 and S5M 24253 be approved. Are we all agreed? We are agreed. Thank you very much, and we will report to Parliament accordingly. Can I thank the Cabinet Secretary and his officials for their attendance today. We will now move into private session on a different platform. I suspend the meeting and we will resume on a different platform in 3 minutes' time. Thank you very much.